Thank you all for taking time out of your, we probably want to switch this one off. Out of your crazy busy schedules to share the information this morning. As the title says, we're examining targets and best practices for new hospitals, and we're going to share a lot of information with you today that will draw our conclusions from, but have a real implication for everybody in this room individually and for the companies that you work for. So there's real outcomes from the day. So this is not a standard tell a story and absorb what you can. This is, we're looking for suggesting, recommending, proposing real systemic change to the way that we plan, develop, and build new hospitals. And we'll work through panel discussions, and we're just thrilled with the people who've been willing to step up and be part of the conversation this morning and this afternoon. And big day coming. Let me begin by acknowledging and thanking our industry members of Greening Healthcare. You see them on the slide here. Some of them are exhibiting here today. Take the time to chat with them. And it's not just that financially they make possible what Greening Healthcare does. They're also tremendous input in terms of technical content and guidance and advice and priorities. So we value our industry members very highly. Let me, yeah, so we'll go right, and let's, and mostly we'll thank, I'll come to our particular sponsors today in a moment, but mostly we thank Cortellucci Vaughan Hospital both for hosting us today in this beautiful setting and facility. There's nothing like being here and being in the middle of a highly energy efficient facility. It kind of makes everything real in terms of the conversations. But also, again, having been our host and sharing so much of the information, we spent a lot of time with your team, David, over the last several weeks pulling the program together. So if I could begin by just passing this over, a welcome and a background and a bit of the story of Cortellucci Vaughan. David, if you'd like to join us, that would be great. It's the usual way.
I think I can actually even handle this. Okay. Thank you, Ian. Can everybody hear me? Welcome to Vaughan. And the summer's not over. For those of you who've worked in the ministry, and I see a few in the room, summer's not over till midnight, usually on September 21st. But really happy to have to welcome you to an in-person event in Vaughan. And I want to welcome you on behalf of Mackenzie Health. And I want to thank Greening Healthcare for organizing what should be a great event, and for people for making the trek to come here. Sometimes coming across, even if you're coming from the GTA, even if you're coming from north of Steeles, it seems like you're traveling across an entire province or country just to get across the GTA in one day. I do understand that we do have the award for the longest travel here is Miles, who came the most miles from Manitoba. So thank you for coming here. And we do, agree that this is a super important topic. And I'm going to give a little bit of history or background for those of you who may not know about the journey to how we got here. And then later on, Patrick Zarabecki, who's our FM contract manager here, who will give you the real deal. I'll tell you some things. And you've got some great orientation landmarks in the background. So for those of you who don't know, Canada's Wonderland, that's where all those big roller coasters are. So we're looking south onto the city of Toronto. Vaughan used to dub itself the city above Toronto, but it did drop that name, thank God, years ago. But for the longest time, Vaughan had the dubious distinction of being the largest city in Canada without a hospital. So if you can imagine, Vaughan, the population of Vaughan is 333,000 people, and this hospital is opened in 2021. So for the longest time, Vaughan was without a hospital. But we think we've made up for lost time with the facility that you're in today, and hopefully you'll get a chance to do some of the touring to see what we've done here. But I think I have a couple of slides here. Just to put it in context of Mackenzie Health. So Mackenzie Health is a two hospital model of care. So you're today within the Cortellucci Vaughan Hospital, which is the new hospital in Vaughan. And historically there was and continues to be a Mackenzie Richmond Hill Hospital. And if you go back, over a decade ago, that was York Central Hospital. And when Vaughan Hospital was added, it was the first net new hospital in the province in more than 30 years. So if you can believe all the population growth in this province, there were a lot of new hospitals built, but those were all replacements. So the first net new hospital is Vaughan, and we evolved and had to adapt and create. So we were in the driver's seat to create a two hospital model where we had a model of care where we had certain specialized services unique to individual sites and core services that were offered on both sites. So it's been, I'd say, an effective model, a lot of work to get to the point of where the services would reside, what the volumes would be. And all I can say is we got it all wrong. The volumes are way higher. We were, pretty well full in both hospitals as we opened, and so continue to try to adapt to that situation. And I'm sure many of you out there are experiencing unprecedented demands for services. So this just sort of gives you a little bit of a before and after. So if we were to go back to the origin of the project, our initial approval, when the government said you're approved to have a project, that was in 2011. At that time, we had about 85,000 emergency visits in a single site in Richmond Hill. You can see, sort of our rough complement of staff, volunteers, physicians, and our bed complement. And our 20-minute drive time map was about 420,000 people could reach that site within about 20 minutes. Now in rush hour, that number may go down to about 10,000 people, but you can kind of see what we were like at that point. So now that we're in 2024, where we have two hospitals, so the original Richmond Hill Hospital and Cortellucci Vaughan Hospital, we're now on pace for 230,000 emergency visits within a single year across the sites. Our physician complement has grown significantly. Our staff complement has almost tripled from a decade ago, and our volunteers as well. So you can see this sort of massive unmet need that was being accommodated by having a two-site model versus a one-site model. And then probably one of the factors that's really impacting us from a service delivery is our drive time. Those that can access either site within 20 minutes, it's over 1 million. It's probably much higher than that because of the highway access. And we're really experiencing a significant change in who comes to our hospital from far and wide, and even the EMS from different municipalities will come to this location because of the ease of driving here and the offload procedures. A bit of a reflection. Now, Patrick will do much more of this later on. He'll probably be much more accurate than I'll be. But I've had the pleasure of being here. I just marked my 15th anniversary last week, 15 years at Mackenzie Health. And so I was here since the start of the journey. In fact, 2 months into my role, York Central Hospital received the planning mandate to plan for the Vaughan Hospital and the two-site model. And so we were on a multi-year, decade-long journey that has resulted in now we can reflect back. We're open as a two-site model, but as you'll experience or you've experienced in where you are, these are journeys that are infinite. They're not finite, as much as we like them to be finite. So in thinking about this, I sort of came up with 4 points or 4 lessons or four themes that I thought would be helpful to relate to the sustainability, decarbonization, and relating it to the journey that we're on. And so point number 1 is that we're in this together. And to bring this facility, our 2-site model to what it is, we did this with others. No single party can do this. So whether it's sustainability, whether it's patient designing for patient care needs, for staff needs, et cetera, we need to rely on each other. So internally, there was a strong board and executive commitment towards all goals of the project. Patrick will cover our planning principles, of which sustainability was one of the major elements and principles that ties us together. A strong project team, strong advisors. So in the case of a DBFM project, obviously we had PDC and with the support of IO. So that was sort of the internal extended team. But really the horsepower and the expertise of Project Co. And their depth of knowledge and expertise. Some of them are in the room today, so that's great as well. And so that helped to bring our sustainability and our success to a new level. So with plenary as sort of the overall organization in this, but bringing together PCL, who are obviously world-class in, well, it says right there, sustainability, quality, and safety, technology, innovation, and creativity, right there in the corner. Stantec, who were the architects for this, which was great, and Johnson Controls, which brings, an international powerhouse towards and commitment towards sustainability. So that was the together element here. It brings us to this enviable spot of being on the top of the list with Humber. And you know what, if you're a sports team, that's great. You want to stay at the top of the list, the top of the standings, and you never want anybody else to catch up. But this isn't competitive sports. So really, I think the goal of a session like today and those who are really trying to lift the sector is we want everybody to be at the top of that list. We don't want to sink down, but we want everybody to be able to raise their game. And because to really make a difference, everybody needs to be able to elevate their game. And so we think that today's session is one great step towards that. My point number 2 is it's a journey and a destination. So usually you say it's a journey and not a destination, or the other way around. But this is both has elements of a journey and a destination. There's no shortage of really out there targets and timeframes. So every 5 years seems to have some marker in it, some target every decade. So whether it's 2030, 2040, 2050, there's all major changes that are and outcomes that are set out, whether that's being net zero by a certain year or something in between. In our project, at one point, we had a decade plus mission to achieve something, and it seemed like an eternity. That date just seemed so far out. It was hard for people to wrap their head around it, and we needed sort of like that marathon analogy of, preparing for a marathon and having checkpoints along the way. But now that we're 3 years past that, if you look back in time, it seemed like a blip. And there are many setbacks that could have knocked it off its rails. So with new hospitals, it provides this huge opportunity to get it right versus in older aged hospitals like our Richmond Hill Hospital, like many of the hospitals that people in this room might have the pleasure and the burden of caring for. There's a lot of grind, a lot of systematic gradual improvements of aged facilities. So those are, what we've learned is those are 2 completely different journeys. So we're happy to help on journey number 1, which is how we got to this and this being successful. and Simba team, they'll welcome any help that you can provide on journey number 2, which is Richmond Hill. Much of it built in the 60s and 70s. The music was great from that time, but the building's not so great. The point number 3, or lesson number 3, is our choices matter. And really, these are choices that are made. So I find in this topic, there's many external influences on each organization, on whether it's a decarbonization strategy or sustainability. There's regulations, there's incentives, penalties, carrot sticks, all those sorts of things. Our strategy guru that we ascribe to at Mackenzie Health is Roger Martin, and his definition of strategy is it's an integrated set of choices that positions an organization to win. And so in my mind, the external influences, they're part of our context, but they don't define our strategy. So for instance, the 5-year ECDM plan, which many of you would have completed and under regulation needed to post by a certain date, right? That's important, but hopefully the strategy goes beyond that. That's not, it might be a catalyst, but not the driver, and that's part of the journey, but not the entire journey. In the case of this hospital, we had an integrated set of choices to make this successful. Patrick will share later the planning principles to be able to balance and achieve a whole lot of outcomes, with sustainability being one of them. And with the help of many of our team and our advisors, we were able to combine some of these choices for better leverage. So so we leverage green and healing environments for better patient care outcomes, improved staff morale. Many note, pharmacy and lab are actually on the 3rd floor with a green roof visible to them. In most organizations, they're sort of banished to the basement. So those were some of the things. All patients, they have a view of any roof that is below them. It's a green roof, and those are all elements that can help with patient care outcomes, views of nature, and also have a great impact on sustainability. And then my 4th and last is this sort of, I don't even know what the title of this is, but I kind of call it the hospital paradox or the double whammy. But hospitals, as we know, are large buildings. This building is 1.2 million square feet. Combined with Richmond Hill, we have 2 million square feet, not even including some of our other offsites. Hospitals are getting bigger. They're very energy intensive buildings due to the great and noble activities that go on within them. But both of these are known contributors to climate change. And buildings are big emitters, and high intensity buildings are very big emitters. So and as we know, climate change leads to increases in respiratory problems, particularly for our most vulnerable populations, like seniors, who are our fastest and most important group. And then add to the mix climate anxiety, which is a real term. If you go online, you'll see it on, Yale, Harvard, Cleveland Clinic, Mayo Clinic, and it's impacting the mental health of many, especially the younger generation, who basically believe that the older generation is not doing enough or they're causing climate change and not doing enough to address it. So, one could say that we're actually, as a sector, contributing to creating our own patients, which that's a great retail model, but that's a horrible healthcare model. So I think that sessions like today's, they give us an opportunity to be leaders in this, to elevate our game, and to hopefully reverse this type of paradox that we experience. So just in conclusion, I do hope that everyone today enjoys the session, that you listen intently, contribute, that everyone leaves today with a new idea or a new contact, or rekindling an old contact. Maybe you leave with a new inspiration, and maybe that will snowball into something bigger that could impact your own organization or could impact the sector. And just as an added note of pressure on this, but our kids are counting on us. They will ask at some point, or someone's kids, if not your kids. And eventually our kids' kids will ask, and they'll say in 2024, you know, what did you do about this? Because now we're in this year and look what's going on. And hopefully you can look back at the choices and the trajectory that you can help to be a part of something that's so big and so important. So on behalf of Mackenzie Health, thanks again, and hope you enjoy your time today in Vaughan.
David, thank you. I can assure you that the 4 messages that David just shared with us, we'll come back to them over the course of the day. If I could pick up on a couple, we're in this together. That's probably the core message of the whole thing. We're going to share in just a moment what the actual results are, what the outcomes are of all of your work in building new hospitals over the past 15 years. And the idea that none of you individually can lead to better outcomes, but when the team, as has happened at Mackenzie Health, when it works together, we can get better outcomes. And hopefully from today, we'll be working more towards reaching out to each other and looking at the problem and working its way through. And I'm coming back to the problem in a moment. I also like, David, your choices matter. I believe Pythagoras referred to choices as the hinges of destiny. I think we heard that in Winnipeg last year at the chess conference and the keynote. Choices matter. Coming out of today, we're all going to be making choices about what we do on a go-forward basis, and they do matter in terms of everything David said, in particular the constituencies that are looking to us to get this right. But let me, if I may, this is interesting. Begin as we do with every Climate Challenge Network event with acknowledging the lands that we're working on today. And you can read this yourself, but we do respect the ancestral and the unceded territory of the many nations that came before us and that we share these lands with today. These are the traditional homes of many nations, including the Huron-Wendat, the Haudenosaunee, the Anishinaabe, and the Mississaugas of the Credit River. In particular, the treaty that governs these lands is with the Mississaugas of the Credit River, Treaty 13, which was the Toronto Sale Agreement. And what we're doing today, we hope that will make a meaningful contribution to the shared responsibility we have as stewards of the planet and stewards of the environment. I think most of you would agree that we've made kind of a bit of a mess of it recently, and this is one of the chances we have to turn some of that around and do something meaningful and contribute. So the land acknowledgement is very important to us. As are our exhibitors. People around this room here, again, they're not just here to talk to hospitals, they're here because they're part of this conversation, they're part of the work that needs to be done to get to better and different outcomes than we've had before. And once again, we just simply couldn't do this without the help that we receive from these organizations. Please take the time to chat with them, understand where they fit into this big mix and how you can work with them to lead to better outcomes. And I will not break into a rendition of Happy Birthday to Us, but on another occasion I might. This is the 20th anniversary of Greening Healthcare. It was back in 2004 that Sunnybrook and West Park, the CEOs there, got together and said, even back then, 20 years ago, these are significant, important problems that we're trying to tackle here. It seems to make sense that we work together on these things rather than all of us trying to invent the wheel. So that's where Greening Healthcare was born 20 years later. We're still working at it, but we think we're making progress. And again, we thank you all for being here today to be part of that ongoing journey. In some ways, the work has only just begun. So what we want to work through over the course of today is you've heard the welcome, and David, it was touching as well as factual. It was very, very helpful, set the stage wonderfully for the day. I'm going to talk next a bit about the climate crisis. Where does it fit into this conversation, into the story? And in particular, as David said, when our children ask us in the future, it's a bit like, what did you do in the war, Daddy or Grandpa? What did you do in the climate crisis? I think hopefully this can be one part of the response that you can give to them. We tried, we got together, we worked on this. So I want to talk a bit about, for context, about the climate crisis. Then we have 3 panels. One panel is looking at the early stages. Like if we don't get the outcomes we're looking for, where did the problem or the issues or the good things like Cortellucci Vaughan and Humber River and Peel Memorial, where did they begin? Was in the visioning, the planning, the design. So we want to get through that early stage conversation with a group of people who've been there, done that, in some cases repeatedly. Let's look and see what the performance of Cortellucci Vaughan is. Was it always good? Did they have challenges along the way? And again, thanks to them for being open and candid about this stuff ain't easy. It's not what we'll be thinking. It's not easy. It takes work. It takes effort. So that first panel, we'll look at the early stages. The second panel after the break, we'll take it from once you've built the thing, what does good practice commissioning look like? And from commissioning, what does facility management look like? And what is building operations? I look around this room and there's some real experts in this field here. And keep in mind, we got the panels here to lead the conversation, but all of you are part of this discussion. You're here today because we want to hear from you. We got microphones we can share around, and we'll gallop around the room and get the thoughts. All of this is going to be recorded. And for your reference, with interest and support from Natural Resources Canada, we've been reporting on performance of new hospitals for 7 years now. This year, we're going to turn this into a best practice guide. So today, we're looking to capture all those best practices and document it in a way that you, on a go-forward basis, can use going forward. And again, thanks for Natural Resources Canada for helping us with that. But that will be the outcome of this, will be to document everything we hear today and everything we've learned from you into a product and outcome that you can use on a go-forward basis to hopefully not make the mistakes that we've made consistently in the past. We then want to recognize top performing hospitals. That's my favorite part of my work, is this is not by any means doom and gloom. This is all about challenge and opportunity, but we got top performing hospitals in this room that we have our presentations to say, great job. Thanks for leading the way. Thanks for showing it that this can be done. Then after lunch, there's 2 things I think really matter. Cliff Harvey, bless him, is going to lead a conversation with some fairly senior people within the room about lessons learned. So we've been at this with new hospital construction in Ontario for 20 years now. It's a North American issue. The data we look at across North America, it's no different. We've got exactly the same problems in California and New York as we do in Ontario and Manitoba and British Columbia. We have the same data, the same results coming out. But lessons learned is the big part, and that's going to be the highlight. So we're going to hear a lot about what happens this morning, this afternoon. We're asking Cliff and his panel to pull it together for us. What have we learned over the past 20 years that we can carry forward to consistently get it right the first time on a go-forward basis? Then, if you'll allow me, I'd like to come back at the end. If you are planning to skip off early, my strong guidance is don't. This bringing it together at the end, we're going to try collectively, and we want to hear from you as well. What did we hear today? What can we do differently? In particular, what are we going to do differently tomorrow? This is not aspirational going forward. We're going to identify very specific issues within that whole process where market failures, where process failures occur. And we really want to hear from everybody. What have you heard? What do you think? What strikes you as being the 5 top things that if we do these better on a go-forward basis, we're going to be there? So that's our story for the day, the site tour. If you haven't signed up for the site tour, please see either Kelly or Ingrid during the break and do so. There's one thing talking about this, and we can tell you how much gas and electricity Cortellucci Vaughan is doing, but it's a whole lot different to get out there and walk the corridors and walk around and see exactly how it's happening. We're grateful to JCI for for sharing their secrets and their experience and their practices, which all of us can learn from. So if you haven't signed up for the site tour, I suggest you do so. That's our plan for the day. Should be enlivening. Say the formal session will finish at 3, the site tour follows. You're free to go, and after that, expect to hear from us in terms of where we go from here. So here's David back again, and I think this might be the parts that you were expecting. It got a bit scrambled up, but so Michael, I'm a bit confused now. Are we now into Patrick's piece? Let me just, okay. Forgive us, last minute slide shuffles. Any of you been through this before? I once, as a young engineer, gave a presentation to the World Bank in Washington. And back in those, we had transparencies, you know, those things, and the overhead projector. And a nice gentleman from Siemens in Europe was kind enough to do my slides, except he dropped them all on the floor, and the slides proceeded to come up there in reverse order, back to front and everything else. So I was figuring if I got through that one, I'm probably going to get through everything. So we'll just get through this one as well. Let's talk about hospitals and the climate crisis and where do you fit. And David, again, you picked it up beautifully. You're creating your own business with climate change. Respiratory diseases, if you, the recording of Dr. Ronnie Cohn, who was our keynote 2 years ago, the CEO of Sick Kids, he related 86% of the children's sicknesses that they see to climate change, directly or indirectly to climate change. So you're both, as you say, large emitters, and at the other end, you're picking up all the damage. People who get injured on the front lines dealing with floods and fires. But today we want to really narrow this down to the energy efficiency of new hospitals. So let's start with a visual that I hope everybody will take away from here as being the nub of the problem, of the challenge, and of the opportunity, because we all have the opportunity to make a big difference here. I'll leave you a moment to pick this up, but each one of these horizontal lines is a hospital, and they're all new hospitals. Most of them were built since 2015, a few since 2007, but these are new hospital facilities. The blue is their electricity consumption per square foot. The orange is their thermal energy use per square foot. In most these, I don't know if you can see it, but on the left-hand side there, each one of these is from different jurisdictions, from Ontario, from Manitoba, from California, from New York. So this is a North American picture here. There's 37 facilities here. So the key messaging is at the top there. You can see the National Energy Code. This is what this is about the level of energy use that if you meet the National Energy Code, that's what a hospital would use today. That's the white kind of bar towards the top there. Up there, we got St. Joseph's in Hamilton. We've got St. Joseph's Parkwood in London. We've got Peel Memorial. So the top 6 are all continuing care hospitals. Mental health, continuing care, complex care. Number 7 and 8 are Cortellucci Vaughan and Humber River. Best of the acute care. Major acute care facilities, world-class type facilities. You see it all around you here. Comparable to anything in the United States, in Europe, in any other part of the world. Those are how good we can be, and all of those are clustered around what the National Energy Code says we should be. Everything else there, you can see the damage. Nothing else has come close within, and some of the hospitals at the end there are significantly less efficient than the average ancient hospital with its steam plant. So visually absorb this. 80% of the hospitals on this list failed to meet even the National Energy Code. 80%. It's, you know, we hate to dramatize because it tends to turn people off. But this is kind of a colossal market failure, despite best intentions. There's no designer in this room, no commissioning agent in this room, there's no constructor in this room. There's no hospital in this room that didn't set out wanting the most efficient hospital they could get. Yes, sir. As I say, there's a few there that go back to 2007. So for example, Brampton Civic is on this list, most since 2015. Yeah, so genuinely new. And it'll come back to this because the likelihood is the majority of people in this room are directly or indirectly connected with some of these hospitals. And if we were to start with one of the failures right now is you probably don't know it. So Greening Healthcare has a practice that we don't shame. We celebrate the top performers. We try to learn from them. We share it with everybody else. But we don't do shaming. So we don't write the names of, who is that at the bottom there? That's the evil. Because again, best of intentions are there, and most of them don't know. There's one story I had recently when we were sharing this information, was that we were on a call with the person that had informed the people responsible for one of these hospitals where they stood. They were stunned. They were heartbroken. Why would you not? I just heard that something I created, put my heart into for 3 years, and it didn't turn out very well. They believe because they were LEED Gold, they should be great. But they're not. There's no, LEED is a great system. I was the chair of the founding chair of the Canada Green Building Council when we brought it into Canada. Changed a lot of things for the better, but it's not a proxy for energy efficiency. That's a separate subject. And it's one you have to really pay attention to. But I say, keep this in mind. If you don't know if one of your hospitals is in that group, find out. We will be informing every hospital on this chart, including those in the US, of where they stand and how much they could save, and asking them to make a commitment that by 2030, which is the next big milestone timeline in terms of greenhouse gas emission reductions, by 2030, you can fix this. Because all these hospitals have got the bells, they've got the whistles, they've got the heat recovery chillers, they've got the building automation, they got all this, they got modern code standards for envelope, they got everything they need to get it right. Let's make the commitment that by 2030, we'll get all of these to where it is, and I'll show you in a moment what that stands for. But remember this, right now we're not doing, collectively, we're not doing a great job. And we've got to bring it together. And again, going back to David's comments, we're in this together. We're in this together. None of us can fix this individually. Together, we absolutely can. The hospitals, with the designers, with the builders, with the operators. There's a lot of stuff on the Greening Healthcare website you may want to take some interest in. And it's all open. We publish everything, whether you're a member or not. So these guides are there. There's the story of the Humber River Hospital from Bob Collins, the CEO's standpoint, as well as from the physical and technical standpoint. And the one in the middle is research that Amandeep and his group did into, if we look at the sub-meter data from all those top performing hospitals, how much energy do the top performers use? How much for lighting, how much for fans, how much for heating, how much for cooling, how much for medical equipment? So we got all that breakdown and we benchmarked those against each other and said, what would the best hospital look like? Because intriguingly, neither Humber River nor Cortellucci Vaughan have got everything right yet. They're still working on it. They haven't got everything scheduled that can be scheduled. Humber River doesn't yet have LED lighting. It was designed at the time when fluorescent was the range. So even the best have got some ways to go, which means, as you say, you want to stay at the top, but everybody else has even more catching up to do. But these documents are there. If you take one takeaway this evening, just open them up, take a look. They're easy reads. These are not deep, heavy documents. They're really simple stuff. This is what high performance looks like. Go read it. The standards in the middle there, which look a bit like this, they're being used by design teams everywhere to calibrate energy models. So where historically energy models have been a whole bunch of rules of thumb and assumptions and metrics, nobody quite knows where they came from, but they often come out of the government. You're told what to use. But when you put a whole bunch of wrong assumptions together, the idea that the model will deliver a right answer is kind of one definition of insanity. So calibrating your energy models for every hospital going forward to the best of the best, this is what they look like, you're going to get even better results. because you can get every component of energy use right. So one of the memories here is acute care hospital. If you're designing one today in the Toronto climate, 30 is a good number. We like round numbers. Like 32 is not bad, 28 is brilliant, 30 is not a bad number. So if you want to take a look at all the hospitals you have in the production line right now, if the target is over 30, we want to hear from you. Because we're starting off down the wrong path. We start off with the wrong target, the likelihood that we're going to get high performance is not there. But for acute care hospitals, that is the number. For continuing care hospitals, mental health, continuing complex care, the new West Park, those kind of numbers, 20 is now doable. Those hospitals you saw at the top of that chart, that's the kind of level that they were at. So 30 and 20, take those numbers away today. A new acute care hospital, the target should be 30. Easy to weather normalize wherever your hospital is from Toronto. We can do that very easily. For continuing care facility 20. These are the numbers, these are the new standards, these are the empirical metrics that say learning from the best and sharing it with the rest. Let's get to these kind of numbers. And for me, it's always impressive to think about what's this worth? Because we hear so much that we can't afford to get it right. You know, it costs too much to be efficient, and we understand the budget pressures. We don't believe that any of those top performing hospitals spent excessive capital, but they, as Bob Collins at Humber River likes to say, they saved $1.8 million a year against the norm of those, the kind of top quartile of hospitals. $1.8 million a year over 30 years with inflation is close to $100 million. This is real money. So there's no economic argument against this. It makes all kinds of business sense. It's just a process challenge as to where we go from here. These are the numbers. If just these 37 hospitals get to this high performance standard that we just mentioned for acute and continuing care, if we imagine that emissions in future are going to be expensive, so the electricity and thermal numbers are at current utility prices, the emissions we're allowing for $50 a ton. It's going to be at least the kind of magnitude we get to if we're taking this seriously. Those 37 hospitals can save $35 million a year. Over 30 years, you could build a new hospital for what we're wasting. Like we're wasting in terms of emissions and we're wasting in terms of utility costs. And we can together get this right and avoid this and save money for healthcare, help the environment, help the planet, all of that good stuff. It's kind of irresistible. So we're going to be exploring this over the course of the day, but the idea is when we brought LEAD into Canada, it started the idea of integrated design. Instead of having the owner say what they wanted, the architect figure it out and give you a bit of mechanical space here, electrical space there. We said, if we all get together, we can do a better job. And we did. Integrated design worked. We're saying there's a next level now. And that next level is integrated performance, and it requires all the players, that whole process, getting together and talking about performance. And while that's going to be immensely valuable for the hospitals yet to come, why don't we start with those 30 hospitals that failed the first time around and figure out how to fix them? So we'll come back to this later this afternoon. Our challenge to everybody who's involved in these hospitals, either in this room or beyond, is if tomorrow morning one of you takes the lead and makes a call to the other members of the design and operations team and says, we see the numbers here, we're not very happy about them, we think we can fix them, and we're going to get it done by 2030. You saw the impact that would have on greenhouse gas emissions. They're big numbers. That's kind of the challenge going forward. Can we learn to work together to fix this? And if so, let's do it with hospitals that are already operating. Because today we're going to hear about what went wrong, and we will know how to fix it. Together, we're smart enough to fix it, but individually we can't. So this is what we're going to be heading towards around planning and design. And Cliff, thanks for your help with kind of packaging this pieces up. The planning and design, what went wrong there, procurement, what went wrong there, what went right there. We're going to be asking what's working really well now, because we aren't lacking good stories. during construction and commissioning, and then during facility management. That's the whole process that leads to highly efficient hospitals. And the ones in the bottom part of the chart we looked at, there are failures at one or multiple points within this process that led to those results. We fix those failures, we get the hospitals to where they should be as high performers, and importantly, we then have learned how to work together to get this right the first time with the new hospitals in the production line right now. 5 years from now, I hope to be standing here or somewhere else and talking about the last 12 hospitals that have come off the line in North America. They're all at the top of the chart. We figured it out, we fixed it, we got it done. Great job, us. And that's where this becomes quite personal for every one of us individually, but also for our companies. How can we do this? How do we realign what we do and how we do it to get the results there? So, our goal, we want to focus today, let me talk, in the future, we want to talk about the energy transition. It's a huge deal. What does that look like? How do we go from big steam plants to heat recovery chillers to in existing hospitals? How do we make that happen? So all those things at the bottom we will be addressing as greening healthcare in the future. But today, we want to leave the thought with you. If we can just make every new hospital energy efficient, we get halfway. That's 55% emissions reductions. We get more than halfway to net zero. And it's cost effective. And we know how to do it. And we've already done it. We're just not doing it consistently. So we want to really focus on how do we make hospitals more energy efficient and try to keep the conversation focused on that area. Let's solve this problem. And then we got that whole bunch at the bottom there to deal with on a go-forward basis. But this is the attention today. Let's get this right. So if we could, Patrick, I think, and Jason and Amandeep, do you want to start your end of the panel discussion? Then we'll invite the other panelists up in just a moment. But if you could run through, building on David's comments about the Cortellucci Vaughan story, and Amandeep and Jason, if you can speak to the energy story, how did it get to where it is today? That would be enormously helpful. Patrick can leave you to push the slides, and if you guys want to grab a microphone each, and I can't wait to hear.
Thanks, Ian. I'm Patrick Sarabecki. I'm the contract manager here at Mackenzie Health for the P3 hospital. Been here since 2019, about a year before we opened. So wasn't part of the design development process, but certainly was here with all the partners as we completed 100 CD and prepared for opening. Some of these David covered. The total project cost was $1.7 billion. That includes not only the design and construction, but also the equipment and the complete operational term, so 30 years. It's a 350-bed facility. We have 11 floors with capacity to expand to 550 beds. So we have two shelled space floors, 9 and 10, that have yet to be completed, that are waiting for future funding and future capacity. It's a 1.2 million square foot facility. Official approval of the project was in 2011. So you can see that it takes about a decade to get something completed and opened of this size. The RFQ was in March 24. Contract was awarded to our partners, Plenary and their strategic partners, obviously PCL, Stantec Architects, and Johnson Controls, our TKL, and RBC Capital Markets was the funding. The groundbreaking was in October 16. Construction completion was August 20. And the opening of the healthcare facility for I guess the proper term is healthcare system solution. During COVID, we were the overflow for COVID patients in the GTA. And that opened on February 7th, 21. So we were able to pivot, open the hospital for those patients. And we didn't open some of the medical imaging, day facilities, ORs, and ER right away. to accommodate the COVID surge. And then we opened as a full-service community hospital on June 6th of 21. So we've been operating for about 3 years. As you can see, the journey, really started in 09 when you start to plan for this. But the important part of this slide is as you prepare for construction, we really looked at our partners that we had in the existing facility, all of our technology partners, including Philips, who does all of our MES, and Compugen and Epic on the ICAT side. So as we prepared for opening, there were really big discussions with our partners, our technology partners, to make sure that the existing hospital, things there worked, and then we were going to transfer them here to have a two-site model and make sure that we could expand on all those services and make sure that we were very, very efficient. Some of our key drivers, I guess, as we planned the hospital was strategic focus, community perception, governance, redevelopment, lean and patient-centric planning, technology, and finance and efficiency. So as you can tell, there's a pretty broad reach of core values that we were looking at that we found that were very important. And if we met these things, then we would ultimately have proper patient care. And one of the so the hospital planning principles, again, these were our core values in the years leading up to the design of the facility. We wanted to optimize the patient and family experience through the eyes of the patient, organize services around optimal and efficient delivery of quality patient care, standardize and apply leading practices where possible, design an environment congruent with Mackenzie Health's core values, support change through flexible facility design, integrated delivery of care across sites, and obviously this is a slide that we got from 2018, 2017, and one of our core principles back then was achieve excellence in sustainable green design. Apply technology to optimize patient, staff, and physician experience. Safety and wellness of patients, staff, physicians, and volunteers is paramount, and enable integration of innovation and education. So an example of the patient-focused design that really came to my mind is if you think of the two entrances we have main entrance here for a lot of our medical imaging, and day patients come through registration and go right to medical imaging floor on one. And when you come in through the emerge, the entire building is sort of designed as a patient-focused design. So they come in, get triaged and emerge. They come down what we call the boulevard of care. More acute patients are at the beginning of the hallway, and then at the end you have your medical imaging. And as those patients get triaged and immediately diagnosed and cared for, the higher floors are those that are staying longer. So it just has, even just from a patient flow perspective, a very linear design. We also brought in a bunch of other things for patient focus. We have dedicated elevators, as an example, for the mother and child floors, so that when delivering mothers come to the site, they go right in a dedicated elevator up to their floor. Try to simplify the patient experience wherever we can, as an example. We're empowering patients and staff through connected systems. So my ICAT leader that works with me, Felix, would be able to present this much better than me, but they chose me instead. We tried to integrate a lot of the technologies in order to make the patient experience more easier, I guess. So the building itself is designed with patient care in mind. BAS systems have a lot of additional reporting and things like that for patient rooms. The blinds are automated, lighting's automated, and we've been able to integrate that into like a patient tablet at their bed so that they can control their own environment. and also the equipment and our other partners like Philips and things like that have all been integrated into that patient experience, so that not only can the patients have more information on their care, but also we've integrated all those technologies together. So when they talk, then they're more efficient. They work more efficiently. So with that concept, we consider this the first smart hospital in Canada. It's fully integrated smart technology systems and medical devices that speak directly to each other, maximize information exchange, and enable improved patient care. Smart hospital vision is applied to both hospital locations, so both here and at Richmond Hill. Truly connected patient experience inside and outside the hospital setting, utilize digital communications and the Internet of healthcare things to provide quality healthcare. So I think just in general, we had a very defined vision. We spent a lot of time early on in the design to know what we needed, put the patient first, and then integrated in safety and design and all those things. And that didn't waver. At least what I saw during the end of the design and construction was that there weren't many variations. There weren't many changes. That vision held true. And when that happens, then it stays organized. And I think that had a lot of impact on our energy as well. We weren't expanding the size of the space. We weren't changing this, where medical imaging was or the spaces. They all stayed where they were. And then that allowed for that design to be consistent and to be able to flow through. And I think that's part of the success we had. And I think and then Amandeep, you're up next.
Yes, thank you.
Thank you.
Thanks, Patrick. Good morning, everyone. Thanks for coming this morning. So we're just going to run through a couple of slides on the CVH Energy Performance, and I have Jason with me here. He's going to walk through a few of these, but let me actually dive into it. So you probably have seen this chart before, so those of you joined late, so I'll just explain it again. Each bar is one hospital. Your blue is your electricity intensity, which is equal or kilowatt hour per square foot, and your orange is your thermal energy used in a hospital. And as you could see, the top sort of five facilities are continuing care, and then the first acute care on this is Humber River Hospital, and closely followed up is the Cortellucci Vaughan Hospital. So one of the things that, since we've been tracking at Green Healthcare, is how the facilities have been performing, or the new, especially the P3 hospitals in the last 15 to 20 years. One of the things that we noticed with the Cortellucci Vaughan, which is different from Humber River, was that it took very less time for Cortellucci Vaughan to be at the top of the benchmarking chart, whereas for Humber it was a little bit of more process. And the goal is hopefully that through that sort of work, learning through the experience of Cortellucci Vaughan, that the new hospitals that are coming in the pipeline are going to be achieving the performance for day one. So you're going to hear that theme a lot in this conversation today. Maybe Jason, you want to sort of probably turn on your microphone, because I have questions for you on the performance now. So what you see on this chart is electricity consumption profile for Cortellucci Vaughan. It goes back from April 2020 all the way to June 2024. Blue line is, or blue dots is your actual monthly consumption, and the red dots are your normalized baseline, so which is a weather normalized baseline. So as it gets warmer or colder outside, the red dots goes up and down. So anytime the blue dot is below the red dot, that's your savings, or you can see less consumption than a baseline. So there is a highlighted period, just if you want to talk about what happened during this period compared to the other period, where we see in the rest of the period, the baseline consumption and the normalized and the actual consumption, the normalized baseline consumption are pretty much same. But during this particular sort of an initial period of performance, you see a gap. What's that? And maybe you can talk about in general how the sort of the initial performance came about for the Cortellucci Vaughan.
Yeah, so look, Looking at the consumption during that period, the facility, we did a lot of work to get the building right the first time, getting everything commissioned, set up with schedules and set points and control sequences. Unfortunately, during that period, we experienced a failure with one of our heat recovery chillers. So our coefficient of performance for the site actually increased electrically. And you'll see that with the inverse with the natural gas during that period. So we actually tuned the plant, and it was already tuned by itself from the good work that we did with the sequences with our partners. And the electrical efficiency actually increased during that period. And you can see that once we got the heat recovery fixed, that the electrical performance actually went back to what we were expecting.
Thanks, Jason. I think one of the other things to see on this trend, and which generally what we see in other facilities when they come online, is you will see that initially the consumption is higher. Over the next 4 or 5 years, when they fine tune the building, the consumption start to drop. For particular to Mackenzie or particular to this side, you see that electricity consumption remained pretty consistent from day one, which means that the building turned out to be electricity efficient from day one, unlike some of the other buildings which take time to go to that levels of high performance. This is an interesting one, so maybe you want to talk through each one of those individually, because as we said, like a lot of these things in healthcare facilities and hospitals sometimes takes time, and this is one of those on a gas profile. And again, the same concept here, blue line is your actual consumption, the red line is a normalized baseline. And you see the winter consumption peaking up, and then the summer consumption are sort of your valleys in there. So maybe, Justin, you want to talk about probably number one, like where do you see that initial increase in that consumption in sort of the month of January during that period?
So initially, when we opened up the facility, we wanted to make a heating plant test. We wanted to make sure that the seasonal commissioning was done post SC to make sure that the facility could withstand the fluctuations and the potential failures of the facility that could occur for redundancy. So we shut down certain key critical systems and tested the heating capacity of the whole plant at I believe it was minus 29 or minus 30 that day, and ran with natural gas during that period for a day, if I recall. And that one day caused that massive spike. But before that, you can see we're running very astutely to the normalized baseline because the plant was optimized to the performance of the site from the get-go.
Thanks. And then kind of number two goes, then suddenly something happened and your consumption went way higher in summer as well as in winter.
Yeah, and that's what I mentioned with the electrical performance. We had an unfortunate break of one of the heat recovery chillers. So we still had one operating during that period, which was great for offsetting some of the natural gas consumption of the facility, but we just couldn't make up all the heating capacity of the site. So we actually had to operate the condensing boilers more frequently, which caused essentially the spike of natural gas during that period.
So just one quick observation, the impact of heat recovery chiller is clearly seen on this graph. If you ever think about whether heat recovery chiller in a healthcare facility is a good solution or not, you can reference back to this slide because it clearly shows you the impact of that. And what happens in the next sort of 12 months, you can see that, maybe Jason can talk about that, is when the heat recovery chiller got fixed, Jason probably better tell that story.
Yeah, once we had the heat recovery back up and running, the second one, we actually added more sequences and more fine tuning to this system to actually get better performance from the first year of outcome that we had during that period. And you can see that the blue consumption is below the normalized from what we were expecting, which was great. And we consistently tried to operate during that period. The interesting one that we saw from an outcome was number 3 is during that period, it was really cold for a few days and the heat recovery chiller limits itself. There's just not enough recoverable heat that you can recover for your heat recovery. So we actually had to consume more than the expected during that period.
Thanks, Jason. And there's a little bit of story in the water as well. As you could see, it's above the baseline and there's still work needs to be done, I guess, on the water side. Maybe you want to talk about that as well.
Yeah, for the water systems, we have like an irrigation system, and we've got a lot of good efficient water measures that were implemented with the lead projects and the project agreement with the PSOS, which is the requirements for the facility. During that period, we had a leak with one of our irrigation systems, which we caught thanks to working with Patrick and team. And once it got fixed, we saw a reduction. It's not caused from like steam boiler or cooling tower because everything was efficient during that period.
Awesome. So this sort of, I mean, you got an energy efficient facility, but there's a lot of things that happen during the construction phase. It's not just that something popped out and like, here's an energy efficient facility, but could you walk us through what were some of the conversations your facility team, your design processes you had during that time of the construction that help you sort of make sure that what you're getting is something that you can operate efficiently?
Yeah, so during this period, we had other facilities that we operate for other P3 projects, and we have a unified team that operates and maintains and also reports energy efficiency and make sure that, for example, there's continual improvement in sequences, in set points, so we communicate. And during that period of time, we try to make a sufficient amount of facility management walks. So our team goes and walks the site to make sure if we can access equipment or if we have an opportunity to improve the project for us during our facility management period. We also do a lot of investigations in terms of where to put a proper metering on our systems, because the metering itself is going to allow us to actually identify issues faster, as well as identifying opportunities for improvement. We did also a lot of training, commissioning activities during that period with our teams, including ourselves with our PCL partners and WSP, Stantec, to essentially make sure, during that period to make sure that we had a good understanding of the facility once we took it on, and that our operators had a very good understanding of what to do in what scenarios. At the same time, we had a lot of control sequence meetings. We were going down to the root of what to control a facility. How do we control a facility differently to make sure that things that are optimized to our expected targets are actually performing? So we took essentially our teams worked together and reviewed what works best at our sites and then implemented at this site, as well as Metasys MUI deployment. So the MUI is Metasys user interface, and it allows us to actually see where the equipment failures or root causes are a lot faster. So our teams were able to manage efficiency increases and also uptime. We also developed a lot of SOPs, EOPs for our site, so our staff are ready to actually go and manage.
I think, yeah, that sort of leads it to a couple more slides, which you kind of touched on, the OpenBlue software that you currently guys use to sort of do early detection on some of those issues as well, right?
Yeah, that's right. So for OpenBlue enterprise management system, our sustainability manager helps us with taking in all those energy metering, all that information that we have with Metasys, and integrates it to Metasys, to OpenBlue. And then analytically, I can compare efficiency to operations and root cause of failures or some nuisance or something that's happening with a passing valve or whatnot. Here's a few examples of just some key metering systems that during that period, I can track one to the other, compare, I can analyze and report, which is really helpful on an ongoing basis.
Yeah, metering is an important key element in sort of tracking the performance of any facility, and maintaining those meters to give you the right data is also very important. We see that all the time, that meter breaks and suddenly you don't have the data to look at it for months and months and months. Last but not least, the Metasys, that has been part of your success, that you're able to use that to inform and sort of train your staff. Maybe you want to talk about it.
Yeah, so there's a lot of work done in terms of trying to get a user interface that worked for our facility management team. Facility management members are always busy. They're outgoing, resolving issues at all times. You need something that you can operate, maintain, and analyze on an ongoing basis, but also trust that the system is working correctly. So there was a lot of work done with control sequences, making sure that behind the scenes things were working well. We had a lot of alerts, alarms, and set points. But at a glance, we can see the whole plant. This is essentially Cortellucci Vaughan on one sheet.
Thanks, Jason, and we'll be talking about this in sort of detail in a lot of these panel discussions today around what are some of the elements that we can pick in and sort of choose and then sort of implement those in other new upcoming facilities. So I'm going to pass on this to Ian now. So. Yeah.
Thank you, Anime. And Jason, can you come up and?
Jason.
No, I'm. Mark, I'm sorry. Yeah, of course. Round out the team. So today, as we work through the day, we're going to continually try to come back with, we're going to make the assumption that everybody in this room, as of tomorrow, is going to get involved in taking one of these hospitals that isn't performing so well and working with the team to start moving it forward. So what hopefully we've learned so far is the data guide you. That idea of looking, this is where the energy should have been, and on a month-by-month, season-by-season basis, this is how it turned out. Because going into an underperforming hospital and walking around hoping to stumble upon what's wrong, it ain't gonna work. So using the data, and Greening Healthcare can help you with that. So looking at the monthly data that you just saw there, it worked really well during this period of time. Something went horribly wrong in that period of time. You use the data to guide you to where you're going. So that's message number one. We get the team together, have we got the data? And again, Greening Healthcare wants to help you with that because we collectively want to fix this problem. The second message, I think, really done well there with Jason was the building automation system is your best friend. You cannot possibly figure this stuff out in a hospital without the building automation system there to help you. As you start pushing it and asking more questions, you're going to find glitches with the BAS. That point isn't quite doing what that should do. You've got trend logs, you have all kinds of information. So using data analytics to find the problems, fix the problems, and verify the fact that they're improved is so the starting point of all of this. That's how we get all those hospitals moving up the benchmark chart to where they should be. So with this particular panel, again, we're looking at visioning, planning, design, and construction. And if I may, I want to start, George, with you, if I could. And all of these panels are going to be looking at what's already working well. Like, this is not doomsaying time. What's working well, what can be improved, and how, and in the context of Cortellucci Vaughan, where it worked out really, really well, as it did with others. So, Joe, if we started with, you've looked at a number of different hospital projects over time. If you look at that early stage process, the visioning and planning of this hospital, what strikes you that, yeah, that would have really made a difference? This is how it turned out to be as well as it could. Can you kind of go at that higher level of how do you get started with a new hospital to get it right the first time?
I think it's critical, first of all, you pick the right team. You have to pick a team, select a team that has got the experience. But I think beyond that, the people within that team, I think we don't talk enough about who the kind of various discipline leaders, the people that actually are hands-on with the project, who they are and what they bring. And I think in this case, we had quite incredible people, passionate, and we were all aligned, both with the PDC leadership and the hospital leadership, as well as modern and plan and JCI. So one thing that struck me is that, because this is not easy, and so when I hear, well, what is it about Cortellucci that achieved this level, and why didn't other hospitals achieve that level? It's a complex building, and a lot of things can go wrong, and if there isn't alignment within the team, I think chances are it will go wrong. I mean, there might be some projects that we've worked on that list as well. I don't know. But there was alignment initially, and even though there were competing interests, I think at the end of the day, we were all kind of working together. We were integrated. We met weekly. Our teams met, the architecture team met weekly. We met with WSP weekly. We met with PCL and Modern and Plan weekly. We met all through, and we constantly kept aligning. I should say one thing though, because this is an energy conference, and energy is important, but there are a lot of other competing interests that drive us as designers. And I think somebody mentioned patient environment, clinical efficiency, operational efficiency. And one thing that maybe I would add to your list of issues to be looking at is you talked about energy per square foot.
Yep.
It's also very important that you have an efficient building. You can have a building that is maybe pretty good on a per square footage basis, but maybe the square footage is too big. Is the hospital designed tightly enough? And I think in this process, I mean, there's a lot of things that I could criticize about the P3 process. One thing it does drive, though, is an efficient building in terms of area. Area costs money, but excessive area also costs more to operate over the life of the building, and that's a factor that I think we have to bring into the discussion. It's not how efficient the systems are, and I think working with WSP and Plan Electric, efficient system, we have to meet certain energy targets and modeling, all that. I think we can pretty much nail that, but we also made the building. We met the net areas, and we brought the building size to within small percentage points of what the target was. We were very efficient in the clinical planning. And I think that's got to be talked about as well, is how efficient can you plan the building? And that comes down with the kind of experience and the rigor of design in a very short time period.
As you say, complex buildings. Mark, can we go to you? You're the constructor. So you get handed part of drawing, say, build it, and then it goes on from there. As the constructor in this process at PCL, what do you think worked well at Cortellucci Vaughan? And more importantly, what would you love to have done differently, not just here, but in other hospitals that you guys work on? What's the one big fix that could help them produce consistently energy efficient facilities?
I think George kind of nailed it though with the team structure. Getting it right out of the gate is very important with knowledge, trades, contractors, operators. Everybody's got to be singing from the same songbook. And if you don't have it right, you have no chance. And I think George articulated that very well. I guess the second part of that question for us, it's again maybe looking at the contract types and where IO is headed with some of the models in terms of how they're going to market with more current projects. We're starting to see a lot more collaborative experiences with IO alliance models or ideas from BC partnerships or IPDs, and all those models really articulate and allow for collaboration and really true collaboration amongst the stakeholders. And I look out and one of our biggest competitors, Ellis Don, is also probably our biggest partner. And we're tackling the Trillium Hospital together, which has a collaborative spirit. We're tackling the one in Ottawa Civic, again, similar model there. So, we're sharing experiences and sharing our knowledge pretty freely in terms of the energy targets and how we intend to articulate those, and we're proud of what we do and they're proud of what they do, but together, we've heard it quite a bit. Together, we're going to achieve a lot more and much better outcomes.
Can I push a little bit on this, because I want takeaways. So the idea of collaboration, who would say that's a really bad idea? How do you make collaboration work? So you George, talked about team. And you listed all the individuals. What goes from individuals to team? And if with both of you, because I'm guessing that you're probably involved in some of the lesser performing, what did you see at Cortellucci Vaughan that you think may have worked better? than in some of the other hospitals didn't. What makes team? What do you have to do to get collaboration that really works? Either one of you.
I during the course of the project, there was a couple of times where I had to change senior people on the team, not because they weren't good, but because there was a lack of alignment. And that's not easy to do, because they're good people. But we need to be aligned. We need to trust each other that the right things are being done. But one thing interesting, I was thinking about this yesterday, and what is it we did different? And, in working with WSP, which is, we have engineering in Stantec, but in this case, the team was put together by PCL, and it chose WSP, great firm, different offices. We actually brought in a senior mechanical engineer out of our UK office, tremendous hospital experience, because we want to have a man on the inside. We want to make sure we understood what was going on in all the meetings, because we can possibly, as architects, we have a pretty good understanding, but when it comes down to nitty gritty, we want to make sure that the coordination was there. If every system, you can design the best systems, but if you're not coordinated, then there's a problem. Between mechanical, electrical, structural, architectural, coordination was the biggest issue that made the building successful. And there were coordination sessions constantly. And the one thing I'm not correct is, like you said, when Stantec handed over the drawings, we never handed over the drawings. We were working together on the drawings. Modern was producing drawings. Plan was, PCL was building before the working drawings were complete. So it wasn't like a traditional project where you design, you documented, you then hand over the drawings and build this. We actually worked on it together, and that's one unique aspect of this delivery model, that there isn't, that compartmentalization isn't there. You don't say over to you, and well, these issues come up. We worked on it together and we resolved issues before they became issues. And that coordination, I think, both in the systems, right, and with JCI. Oftentimes I'm sitting in the back room with JCI guys and I go, is this okay? You okay? Are we good? And that kind of thing is very valuable. You have that input from all aspects as the project is being developed. But again, if the people aren't the right people, if they're not collaborative, or if you just don't see eye to eye, then it's not going to work out. I think.
Let me ask on that. How did you figure out that they're not the right people? Again, people to take away the idea. What do you look out for saying this is not working, that you make those changes?
We kept fairly good notes and minutes. If I saw an issue come up over and over again, I pulled people aside and said, why are we not getting this resolved? And sometimes you have to, push people to kind of move along. And, in this, the timing, and it's a fast-paced project. You can't afford to lose a couple of days. And so we, with all of that, not just me, Kevin from WSP and others, we were kind of kept our eye on it, make sure that things are moving along, decisions being made, and if things were not, trying to figure out why. But it's you almost got having a sense of whether something's progressing. And I tell you, if PCL came to us and said, not happy with this aspect, the second, third time we hear it, we have to make a change, because we can't afford to lose time on it. I don't know if that answers the question, but.
Well, yeah, I might just add in that, the ego checking, that gone are the days where a consultant's going to really drive the process down all the way through, especially in a P3 when it's moving quick, right? We have our building systems group in Toronto, which is led by Sean Bloor, and Chris Kruger from his team is here with us today. That team is so instrumental in terms of how we challenge the process and challenge design, because it all goes back to budget as well, right? So we got to get the design right, but it's also got to fit in a budget. And that team is, when building systems make up 50 or 60% of the overall cost of the building, you got to get it right. And when I talk about ego checking, you know, again, the hierarchy of how things used to work with, you know, designers at the top, kind of funneling information down to the contractors, and then we would funnel it down to subs, and subs would funnel it down to suppliers. It's so much more integrated and so much more important that we get it right and understand, you know, where the innovation, where the technologies are coming from. And that's generally led by our suppliers and vendors, which then feed up through our design build contractors. So you mentioned Plan and Modern. You know, we've teamed up with them for many, many P3s and continue to work with them on a lot of very challenging projects. And they're you know, fed through their suppliers, and it all kind of comes back up. And once you kind of get that balance right, you're going to hit a home run. So
I want to move on to Patrick in just a moment, but again, from trigger words coming here. So integrated, David, your comments earlier, in this together. And again, we want to leave a message here. I'm hoping after today there's going to be a lot of phone calls or Zoom meetings or whatever it is that you do these days to connect with each other. Because this idea of integrated coordination, everything else, we cannot fix what we looked at earlier today individually. But together we can. And you get the right players together and you focus on the engineering, the operations, everything else. So this follows downstream is how do we get to where we're going. But Patrick, moving on to you from a moment, you're living with all this, kind of day-to-day basis. If you had your druthers, what would you change that was upstream of your getting involved? Man, if they just fixed that way back when, this would have been good. What advice do you give to everybody on the upstream part of the process? We get this right, we're going to do a better job.
Definitely having the teams in place as early as possible, right? When I started here in 2019, the client side, the MH side, was well established through the design phase, led very, very well by Carol Massicott. Many of you know her. This wasn't her first project. And she had a really talented team with her. So when I got to join that redevelopment process, they already knew the building. They were very integrated. They understood what the end goals were. They had made compromises and efficiencies. Like the one thing that comes to mind is the puts and takes log, right? Is this a big deal? No, it's a small project. Put it on on one side of the ledger or the other, and we'll figure it out at the end, right? And those types of efficiencies really paid off at the end, right? Where we all sort of work together. And one of the things that I think David and I, when we discussed how are we going to operate the building properly, we really looked at retaining that staff, right? So from the client perspective, keeping as much of the intellectual property that designed the building on site. And I think our partners did that too, right? Like I was working with Jason and his team and JCI even early on, and then PCL staff that designed the building were here for a couple of years after that, right? And still are in the wings every once in a while when we need them. So keeping all of those people involved in a project after opening was critical. And as far as, energy impact, definitely some of the things that I've said before make a lot of sense, right? The size of the building, every square foot you can eliminate makes it more efficient, no matter what you do after that.
Yep.
And one of the big things that we've worked with Jason is just ensuring the standards. And speaking with Miles yesterday, making sure that if it's 20 air exchanges per hour, it's 20 air exchanges per hour. A big thing that we struggled with was ORs, right? The ORNAC standard says no less than 20 degrees in an operating room. I have no idea why. It doesn't matter. I'm not clinical. But the surgeons wanted 17, 16, right? Well, that's not efficient because then you have to overcool and look at the humidity and everything else.
In the whole hospital, yeah.
Yeah, so then you really have to push back on those frontline staff and those clinicians when it makes sense, right? Using those standards and keeping it to that standard. And then, we'll look at future projects to eliminate hours where we don't need to meet the standards and continue to look at those CSA standards and things like that. So not over, don't over engineer, don't overuse the space. Use it to its required state.
So Cliff, in the interest of staying with this panel, I'm really looking forward to lessons learned this afternoon. You've always been focused on we need more lead time to get it right, and we still run out of time. So that whole area, and how does visioning and values create this environment where you can get collaboration, you can get a team? Really love your group to take a look at those issues. And Patrick, this was a good one. The whole idea of standards and those darn doctors and surgeons that just prevent us from being energy efficient, and the competing issues. You're absolutely correct. If it fits into your agenda, I'd love to look at some of those things. Emily, can we pass this to you for a second? So these are principles, and everybody's nodding like, how can you argue with any of this? Obviously it's the right way to go. When you get to design, you've looked at a lot of new hospitals that are not working well because somehow nobody calls you in when they are working well. Or maybe they do. But give us some of the design problems without naming names. We don't shame anybody here, we just learn. What are some of the design issues that you found that are going to be really hard to fix after the fact? And why do you think they happened? Because we've got nothing but competent people designing hospitals. Where and how did mistakes get made?
Yeah, thanks, Ian. I think I'm going to go back to the process, and I was involved on the design side of designing P3 hospitals, and then primarily now I'm looking at sort of the operation side. When I look at sort of the historically what happened in their process and try to sort of refresh my memory, there's a lot of emphasis on sort of, okay, we got an energy target as a project code that we have to meet. So as a result, we got to design the systems to sort of make sure that we're meeting the energy target in the end. There's emphasis on sort of making sure the selections are right, and sometimes it's driven, most of the times it's driven by prescriptive sort of language that's used in the contract, less than sort of, energy modeling and targets as a guidance. But the prescriptive requirements around certain equipment actually drive those selections. So once you get that piece done, there's a lot of emphasis on that. One thing that when I reflect back, what I notice is missing is, we talked about a clinical sort of operational efficiencies in a healthcare facility. I would love to see a comparison of similar things for clinical side to see, are we getting the same sort of curve there? Like, are in fact, because there's a lot of due diligence going on the clinical side, we might see most of the hospital that on the clinical operational efficiency, they're turning out to be top levels. Whereas on the operational side, when we especially talk about operational uses, there's not sort of a lot of due diligence going in that process. So there's due diligence going in selecting equipment, but there's no energy meetings happening to make sure that the facility teams are aware how these things going to operate in the end. Like, is it the right valve? Do we have sort of the right heating loop? Is there the equipment sized? Is it oversized equipment? That process of making sure operationally things is going to work in the end is missing from what I see so far. Like, there's a lot of due diligence goes on selecting equipment, making sure they're right equipment, but making sure it's operating right principally. That piece needs to be developed in that whole process. That's where I think is some of those missing elements. And in terms of the design that we see, when you look at a high performance hospital, there are very sort of similar design. There's one consultant may place a boiler on either side of the loop or otherwise, but primarily they're like heat recovery chillers is a primary source. And then you have condensing boilers and small steam boilers depending upon your design. But the design side is pretty, is something that we know it exists, and it's a problem. It's just that integration of that sometimes is challenging, that we see that integration of heat recovery chiller in some of the facilities is an issue where sometimes it's not extended to the whole of the hospital. Scheduling is a big piece. It's a small thing, but it gets overlooked all the time. Like,
sorry, what is scheduling?
Air handling unit scheduling. So there's no conversation going on from day one we're going to have these air handling units. How are we going to schedule them from day one? There are facilities, and we know there's work still needs to be done in a lot of the high performance facilities, is that scheduling is a simple measure that could have been looked, but it's still overlooked in a lot of these designs.
And didn't even get modeled in the first place. Like the modeling didn't assume that you were going to switch things off when they weren't needed. Is that correct?
In some cases, it was assumed, but it was sort of a surprise to the clinical teams. They're like, what are you talking about? It's a hospital, it should be 24/7. And then you tell them, no, it's not 24/7. These are the systems, these are the spaces that are going to get scheduled. So that process itself takes 2-3 years sometimes. Had that been a conversation from day one about the standards we talked about, had the clinical teams been referenced and told them, this is the temperatures you're going to get in these spaces. If you want to lower temperatures, let's have a conversation from day one so we can design those systems accordingly and find those rational reasoning for that. If we talk to them afterwards, they obviously going to say, this is what we have been seeing from every year, right? So that process of making sure the clinical buy-in on the standard of what is your right temperature, what's your right humidity, how the space is going to be scheduled, should be from day one conversation with the clinical teams.
So we got integration and coordination, but maybe not as much with the people that are actually going to be using the hospital as we might have. Mark, you picked up a microphone. That's a sign.
Yeah, I wanted to touch on that a little bit. More so in the sense that, when you talk energy models, when you talk energy models and you look at what a goal might be from day one, in the traditional P3 DBFM model, you don't get that interaction with the operating team or the clinicians or the people who are going to be working in the facility. You start to get that nowadays as IO is switching their procurement regime, which is great. We got a story where one of our current hospitals had a certain energy target, and we ran scenarios and permutations on mechanical electrical systems. We looked at the envelope, and even with a window to wall ratio of 0, we couldn't achieve the targets. So that allowed us the opportunity to go back to the client, go back to the team and challenge the process and sit down and, understand what their assumptions were. And hey, maybe we made a wrong assumption as we were modeling. But it allowed us, again, that good dialogue with the owners at the time. So,
And this session with you, Jason, if we could, and we'll pick this up with Glenn in panel number 2. But we say it's normal to see heat recovery chillers and condensing boilers and steam boilers and all that stuff, because that's what we need. But this is still relatively new. This is like 10, 15 years technology. What are the big challenges, and what should we be doing up front to allow you to orchestrate getting the right things on first, the right things on second, so they all work together as a well-oiled machine?
Yeah, it's a good question. The biggest problem or biggest hurdle to take over when you're operating is the multiple inputs of schedules and VAVs and pumps, and all of a sudden somebody wants to have a temperature change. There's a lot of fluctuations that happen in facilities, as we know. And a facility, the easiest thing to do in a facility is just to turn it on and overventilate, overheat, overcool, and then just manage the room, and then you've got the temperature. The harder thing to do is to say, I want to make sure that this area is subcooled only to a certain point, and then manage only a certain amount of rooms and manage humidity, temperature, loads in that facility. That in itself makes it easier if you do everything combined. Otherwise, the orchestration could be simplified, but you'll be a lot less efficient. So we've done a lot combined with our partners to emphasize scheduling on the get-go, temperature set points at the get-go, resets, and a lot of control sequences between the complicated equipment. And you get that from working together collaboratively, but also from working with experience at other sites and integrating that experience for the success of the site.
Direct question. In your experience, could zoning be done better in the design of hospitals to make it easier for you to run it efficiently?
Yes.
Okay. So takeaway, zoning matters, and it links into what Amandeep was saying, you got to get the departments and the clinicians involved to say, how do you want to use this space to get the zones right and so on. So,
and for this site specifically, there was a lot of conversations. Like I remember design meetings being this digital imaging area is fluoroscopy, for example, and it's only open between this and this date, and therefore it can have its own segregated VAV system to help scheduling. And this area that's across the room, well, it's the same department, same sub-department, but it's mammography and it's only 2 days a week. Therefore, it can be scheduled. So we're going to have its own separate. And then you have the integration of, building systems, ventilations, and then you have a lot of variability in your building. And you see that if you look at the building with the analytical tools that we have, you'll see the day-night cycle vary from day to day, from week to week, to month, even throughout the season. But there's a repeatability because the building itself is constantly varying to the needs of the occupants, which is the healthcare provider.
Perfect. Panel, thank you. This is panel number one. It's always the leap of faith. It's thank you guys for stepping up first for the day. We have our first break now, but first, Amandeep, Patrick, George, Jason, and Mark. Everybody, thanks for sharing. Grab your delicious-looking croissants. Take time to visit with the exhibitors. Again, they've got stories to tell as well that we won't get to time today, and we'll see you at 10:45. Thank you. So by now we've figured out how to plan, design, and build an efficient hospital, so we can check the box. That's done. It's not that complicated. We just talk about it. It's good. It's I think, as the panelists said, it's a lot of work. Like getting this right, it's hard enough building a hospital. However it turns out, building it efficiently is just incrementally more work, but it's so worthwhile. And actually, we don't have very much choice on the subject. So moving from planning, design, construction to begin, when we were planning this, we had commissioning as part of that first panel. But we see commissioning, just to share our thinking right now, and we've got lots to learn, energy modeling and commissioning are the weakest links in this whole process. So if any of you are in those businesses right now, we're talking about you. If you get the model right, too many assumptions. If you get the model right and it gets properly integrated, you should get the design right. And where we see design mistakes, it's typically because the modeling had incorrect assumptions. But we wanted to move commissioning to this session because we're really very interested in how the facility manager interacts with the commissioning agent and how extensive commissioning is. So our second panel, I've asked my colleague Amandeep, who is the technical lead for greening healthcare, but has also looked at more hospitals that have underperformed in terms of their energy. He knows more about the hospitals at the wrong end of that benchmark chart than anybody. We've asked Amandeep to moderate this. We got Miles in from Winnipeg, who will get the award for the longest distance traveled. We did that already. But Miles has taken it with New Women's Hospital. We stumbled upon New Women's Hospital in Winnipeg, part of Winnipeg Health Science, last year at the Chess Show. And Miles was good enough to send us the data, and we ran it, and guess what? They're right at the top of the chart, but there was nothing particularly elaborate about the design. And in deep conversation with Miles, the way they put the team together to operate the facility and how they managed commissioning was, we think, was an indicator of how good this could be. So we're really thrilled that Miles was able to join us today. And in the same way as Amandeep mentioned that Humber River took several years, and the first of its kind took several years to get it orchestrated and all the parts singing on the same sheet and getting the kind of results. Glenn's been doing similar work at Providence in Kingston, Providence Health in Kingston, and Amandeep will share, this is the story of how they improved over time. So we always like finding and documenting improvements because that's where we learn, right? If you got it right the first time, then it's got to be easy. If you didn't get it right the first time, then you worked on it and you got it figured out. That's where the lessons to be learned are. So, and Amia's been living with an older P3 hospital down at St. Catherine's, and has now been directly involved, taking his lessons learned from that one into the new South Niagara Hospital. So everybody on this panel has a story to tell in terms of lessons learned, what went wrong, and all of this feeds directly into what Cliff's going to be talking to us about this afternoon. So again, as always, thrilled with the panelists that they would take as much time as they do, not just to be here, but all the meetings that we've had leading up to this to get the stories all lined up. So Amity, could I turn this, there you are, turn this over to you. I promise not to walk away with the clicker this time, because normally I do. And bring your panel up and let's get to it.
Thank you, Ian. Can I ask Miles, Samir, and Glenn to take your seats? So you have 3 microphones. You don't have to share them, so you got your own. Thanks everyone again for joining for this session. So we're going to focus on this particular session around recommissioning, facility management, and operations. This is sort of the tail end of what you get in a healthcare hospital. However, leading up to is as important as getting energy efficient hospitals at the end that could operate, and we'll have a lot of lessons learned that we'll be discussing today through that process. Before we sort of get into the weeds of each of the hospitals, their stories, I just want to share a couple of slides on what are we where are we finding a lot of these commonality in these hospitals, whether that's an existing hospital, whether that's a new hospital which is underperforming. These are some of the sort of the 12 sort of top 12 recommissioning measures that we have looked through and sort of done research. And this is sort of we call it a live list, which get updated as we learn new things about it. And we update this to sort of improve that list of schedules. These measures, once done correctly in any facility, will make your facility sort of get to the top of the benchmarking chart. Now, the extent of that, in some cases, you may or may not be able to do due to some of the limitations. But in other cases, the infrastructure is there, everything is there. You apply the brain power, and then you start doing these measures that will lead you to a high performance building. And you can watch sort of, we have a recorded session on the Greening Healthcare website. If you ever want to look into more into it, you can actually log into the website, and that whole session is documented, which will sort of talk about this in detail. 3 hospitals we're talking about today, Providence Care, New Women's Hospital, St. Catherine's site. They're, as shown on the benchmarking chart, this is the chart you're probably seeing third time, and maybe we'll see a few more times today. This is the whole story we're talking about here today. The Providence Care, as you could see, is at the top of the benchmarking chart among the other continuing care hospitals. New Women's College is also at the top of the benchmarking chart among the other acute care hospitals. St. Catherine's site, as Amir is going to sort of give us more information, give us more details about their sort of how this site turned out and what they would have done it differently, and what they're going to try to do in the next sort of 5-10 years to improve the performance of the site. So there's a lot of learning to happen over these sites and the processes, and that's what we're going to talk about today. Maybe I'll start with you, Miles, first on the New Women's College. Like it is a unique process that you guys did, especially towards the commissioning side of that project. But maybe you can walk us through your sort of learning from the design side and how that sort of the new commissioning process that you applied helped you to sort of get a high performance hospital from day one. If you can sort of share those details, that would be awesome.
Thank you. New Women's Hospital, conventional hospital, conventional systems, and it gets onto this list. It's quite remarkable. It's not a P3. It was not done that way. Yeah, so I think looking back at the design, I don't think you can start early enough with commissioning. And so at the earlier planning discussion, I didn't hear too much discussion about commissioning, but I think it needs to be thought about very, very early. And this is something that they did at the New Women's Hospital. They brought the FM staff in, even at that, I would say, aspirational target level. Because if you're going to start thinking about what are you going to achieve, the people who are going to be operating the building need to weigh in on some of that. What are they going to need to do that? And if they're accountable for creating that high performance, what are they going to do? So they were involved in identifying requirements, keeping and managing expectations, working through issues based on their experience. The other thing I can say is that they're a very experienced group of people. They've been operating in buildings at the HSC campus for many years. So that expertise is critical. I mean, how many of you are, if you know somebody who's good in a particular field, I mean, we're all looking for that, right? That talent pool is not huge. And so bringing that expertise in early is absolutely critical. Having the FM team involved in reviewing drawings. One of the things that I've seen success with is doing page turn reviews. So actually opening up a set of drawings with the FM team and talking about it. Go page by page, take a look at what is there. Is this what you expect? And what are you going to do with it? What's missing? Let's walk through a few scenarios. So this team also then started taking on a lot of the commissioning elements, setting up what are you going to be testing, under what scenarios, how are we going to make the systems fail to show is this working properly, or how are we going to do seasonal testing, that sort of thing. So that was, I think, a key part of it. Reviewing then shop drawings and the construction, and then as you get the building operating, it's the troubleshooting, right? It's how do you get through these things? Now they have to get through them. So that's why I think it's so important for them to be early on. So my message is really get them in early.
Yeah, I think you touched on the point. I just want to make sure that that doesn't get overlooked, is that the process of recommissioning is you had your own team sort of sitting through those design meetings or kind of represented through the design meetings to the end where they're actually doing the commissioning of those equipment that they've seen through that whole process. It's not something we usually see. Like we tend to see that commissioning is sort of treated as something that comes at the end of the project. Where I'm just going to come to you. But that process that you defined, maybe if you're going to give us a little bit of background, like how did it came about? Like whose decision was this to do that differently?
So we can go to questions.
Sure. Sorry, I lied to you guys. Thank you.
I think one of the things that helps, I don't like to focus too much. I like to focus on performance as opposed to, say, certification programs. But I can say that this is a project that got LEED certified. And I think one of the things they decided early on is that they are going to embrace enhanced commissioning. And so I think the reason that it went down that path is to execute an enhanced commissioning program, and they decided to do it using FM staff as part of that.
I think you were just answering my question, actually, so I'll just ask it now. Did your FM staff act as the independent commissioning agent then for the project?
Well, yeah, I would say that they were leading that component of it. Yeah, and
cool. That's very rare.
I don't want to say that they were the only ones driving that, because I know that the design team was involved and there's other parties involved, but they were definitely in control and part of it. Yeah.
And did the builder hire a separate commissioning agent as well?
You know, one of the things I've noticed about coming into Toronto is everyone's very particular about the contracts.
No, I'm actually
very important
about the relationship. It doesn't really matter with the contract.
Yeah. But I think I like in full disclosure, I was not part of that process. So my area is in the evaluation of the performance afterwards. And so when we looked at this, like my interest in New Women's is how do you get this kind of performance and what are the repeatable elements?
Okay, cool.
And
That's
I
cool.
would say that in this particular case, it's the expertise of the staff and it's bringing them in and getting them to drive some of those processes.
Thank you.
I think one of my takeaways from this is having a sort of a hospital, either if it's a DBFM, a facility management MPs, if it's a DBF, who is going to manage that facility eventually, being part of that team early on definitely leads to a lot of good things that will happen. It gives you a roadmap to sort of process to get to a facility that eventually is a high performance, hopefully from day one, because that person has seen through that process and they're there on sort of sitting on the design meeting. And you brought up, I was going to ask you about the shop drawings. So the shop drawing review is also critical because they're looking through that equipment. They're trying to understand what does that actually mean and how it's going to operate. It's not just only drawing, like all the components have been reviewed through people that are eventually going to operate that system. And if they sort of detect those issues, that gives them an opportunity to comment that on the design side and sort of improve those issues. Thank you. I'm going to come back to you, Miles, but I'm now going to go to Glenn with the Providence Care. So again, so if you haven't seen this chart previously, two charts here. One is showing electricity, one is showing gas. It's over the period of from 2018 to June 2024. The blue dots is your actual consumption. Red is normalized baseline. You could see as the blue dot is below the red dot, so that means there's savings. If you look at the electricity side, you could see that back in 2019, the blue line starts to drop below that, and especially in the cooling season, which is peaks, and then it continues to do that. And you see even in the last summer, there's been higher savings. The gas is obviously, you see that a big drop in sort of the consumption after the year one, and it continued to improve and do better over the sort of the following years. So maybe, Glenn, if you want to sort of help us with your story when projects, or maybe kind of go back, like when you were involved in the process and when you took over the project, what are some of the learnings that you found and how did you guys make this as one of the top performing sort of buildings in the benchmarking chart?
I think a large part of the success that we've had in improving the energy consumption of Providence has been due to just continuous commissioning. We haven't ever stopped looking at where we're using energy and whether we can do it more efficiently. You can see on these charts, there are a few things that jump out at me particularly, like the gas consumption very early on was well above target. And that was due to some value engineering decisions that didn't really provide much value. But thankfully, we managed to rectify those, and then the gas consumption came down well below baseline, and we've managed to keep it there through optimization of the heat recovery chiller sequences. And just looking at, again, where we're using energy, what energy is being used unnecessarily and how we can eliminate it.
I know you gave a short answer. I want a long answer on that because there's a lot of things that people want to hear from that story. This is every day for a lot of people. And when they look at it, facility doesn't turn out good. How do they improve it? Your process of finding those issues as a starting point, and then we'll go back to what are some of the learnings that can inform the design teams today. The process of finding those, what does that look like in your facility? Like, how did you know heat recovery chiller is not working? And how do you know obviously you have a target on the gas, that's the starting point, but then what does that process look like sort of on that next 5 years that you took and slowly improve the facility to a point that is turning out to be a high performer?
Well, in the early days, it was entirely defensive. We were just trying to get a solid night's sleep without having heat recovery chillers lock out and crash and the building fall apart on us. So that was a main driver behind the initial sequence improvements for that plant. And from there, it's really just been a matter of, picking a piece of equipment, looking at what the design performance of it is, trying to figure out whether we're meeting that design performance, and if not, what we need to do to get it there. With most of this equipment, frankly, it's about keeping it in the right environment. You look at the shop drawing, figure out what the incoming water temperatures are supposed to be for your heat recovery chillers, you're halfway there. But again, just look at the design performance, what it's supposed to be, and try and isolate why it's not performing to that level.
And then from that learning experience, what are some of the feedbacks you want to, sort of, if you were to do this again, what would you tell the design team to do it differently? So you don't have to spend those 5 years sort of figuring out those issues. There are certain elements I understand that are part of the equipment challenges that comes with it, but can they be improved at the design stage so that you don't have to sort of go through that process of fixing them in the operation side?
It often feels like we're reinventing the wheel when we build a new hospital, because we do know what's out there and what works. So we should be able to achieve this in early days, not necessarily day one, because until you know how the building operates, you're not going to be able to optimize it. But again, if we didn't start from scratch with the design, I think we'd probably be in a better spot in terms of getting the thing up and running in the very early days.
And your involvement in sort of the initial phase of the project, was there JCI involved in that whole process from day one from the facility side? Have you guys sort of looked through each of those elements of the design and say, what about this, what about that? Or do you think there's an improvement in that process that could help other hospitals in the same planning stage to say, bring your FM partners early and have them look at these specific 5 things that will ensure that you get the right product and right solutions in the end?
We've certainly learned some lessons on that front. That stage of Providence was before my time with JCI, so I can't really comment with any depth on what the early involvement was. But we've definitely made a point of trying to get our teams, first off, more integrated with the project delivery and involved much earlier.
Okay. I'll come back on this. Let me go now to St. Catharines. Amir, so this is your savings profile. So unlike Providence, the performance has been consistent, but it's consistent to a point that it's not a top performer. You have seen law through these years. It's been 12 years in operation. What are some of the key things you're learning from the energy efficiency side that will help other hospitals in this sort of crowd today to sort of do things that will help them be a top performer?
Yes, thank you. So we're consistent, but we're consistently bad. So that's the key. We've been in that middle of the pack since the beginning, and since we started looking at it. A little bit of a history on St. Catharines, by the way. It was one of the first DBFM that came off the assembly line. And it was also one of the first projects for Infrastructure Ontario. So I think everybody was learning. There were no best practices. Now we have that set of best practices that we can integrate. And thank you for saying that. It seems like we're trying to redesign every hospital, although we have a template in some of these top performers. So we didn't have that advantage, of course. But what also is true is that, we had a bedding-in period. By the way, that needs to be explained. So we didn't have that energy model that exists right now that is done. We actually had a 2-year bedding-in period. So whatever was established the baseline. So whether it was the hospital operated at the most lowest efficiency was the baseline. So in my mind, we can only do better from there, but we haven't. And the reason for that is that as owners in P3s, we lose the control and it's given over to the project codes. And really, it is up to the project codes now to bring that talent, bring that improvements, or bring that to the owner as to how to improve it. But really, in my mind, in our at least PA, there is no incentive because we pay the utilities. What is the incentive to the project code to go and invest time, money, people, personnel? As long as they meet within the 3% band top and below, there doesn't seem to be any reason why a project co would come and make any improvements. Just keep on operating, keep on paying the money. Then it's, anyways. So I think that has been the main reason why we are where we are, because we don't have a lever to push our service provider to do better. As long as they maintain it, it's fine. That's one. And second is about the learnings, because I did have the opportunity to take the learnings from here. So we actually tried to enhance our PA quite a bit, take the learnings from St. Catharines. We are one of the lucky hospitals that within 10 to 15 years, 10 years, was able to work on the redesign of a new hospital at South Niagara in Niagara Falls. So we took those learnings and we tried to implement, but I'm going to be exactly to what Glenn just said around, it seems like we are redesigning. We started the process with, I'm not sure if I'm going beyond your question.
No, keep you're on the right track.
We started with, and we were very excited, the facilities team was very excited, and we said, we're going to take some of these top performers in your charts and take them as template. We want to better them because even at that time, Humber River was maybe 5, 6, 7 years older. And that means the design was done even 4 or 5 years before that, or a few years before that. So we're looking at 10 years. In 10 years, we should be able to do better. But we started from scratch. It seemed like we started from scratch. And we never, and sorry, I see some shaking heads. I know there are team members who worked on that, and their perspective is very important. And Cliff is going to talk about that process as well, because he was the chief planning officer at the time. But it seemed as if we started from scratch, and we weren't able to even meet what exists. Why did we not replicate, or why can't we replicate what exists? That answer has to come from somewhere else because we weren't able to replicate it. I use that example, I'm going to end there. I use this example all the time. The project itself seems to become the end of the line. So it's like wearing bifocal lens. It's like wearing short reading glasses. Because everybody looks at 5 years from now, we're done the project and we're going to leave. But that's not true, especially not for P3s. For any hospital, by the way, it should be seen to the end of its life cycle. So really, let's look at it for 35 years down there. So we need this bifocal lens. Yes, we have to deliver this project, but its efficiency needs to be looked at. The savings need to be looked at the 35-year horizon or 30-year horizon. And that's where the business case needs to be at.
Amandeep, I got a couple of questions and invite everybody. Can you just raise your hand if you have a question to ask? And I'm happy to scamper over there. I need to get my steps in. But Glenn, what were the value engineering things that didn't add value?
No, there we are. All of our unit heaters and some terminal heating devices didn't have control valves on them. They were deleted as a cost savings. That created some issues in the operation of the heat recovery plant because the secondary heating water volumes were significantly higher than the primary heating loop could feed. So we had water flowing backwards in the primary heating loop. And that obviously caused some issues with the incoming water temperature for the heat recovery chillers, and that woke us up a solid 4 times a night.
It's helpful. And Amandeep, could I ask you to flip back to your top 12 list? Because that's always worth another look. And I don't know if you can see this, but which of those top 12 things is St. Catherine's not doing, and why?
So, like how you gave an example, I'm going to give that example. In the bedding in period, in the first couple of years, the front lobby wasn't designed properly. So how they came up with, it was so cold that it couldn't be used. This was at St. Catherine's 2013, 2014. So how they came to improve that situation was they overpressurized the front, but that's part of the bedding in period now. And they keep it warm enough for occupancy because they've overpressurized it. So we're actually losing energy. That's not what what the pressurization needed to be, but they had to, for the cold air not to come in. So I'm going to say definitely, that was one example of why we are where we are. But the scheduling outside, I think almost all of them need to be looked at. But at that same time, I'm going to go back again. As owners, we have very little control, except for going back to the project co-on. What are we going to do? Come bring something to us, or what are you doing, right? But what is the advantage of them to do anything? Yeah, sure.
So speaking to some of the early Infrastructure Ontario project agreements, there's a reset on the energy target. So if Project Co undertakes a project at their own cost that improves the efficiency of the facility and reduces the consumption, at the 5-year mark, that target resets, which makes it very difficult for either the service provider or the Project Co to undertake any efficiency improvements that involve capital. Because you need to make, a 2.5 or 3 year payback, and that's only if you can execute the project immediately following a reset. So it's very difficult to free up capital for that sort of work in environments like St. Catherine's. So that's one of the reasons that we see that.
I think there's definitely a contract piece that is probably in certain cases, especially St. Catherine, that's maybe sort of hindering the performance of the existing hospital, which could be done better. However, I want to go back to the basics. Like, what is stopping us to build a hospital which is high performing from day one? Like, what are some of those lessons learned that we can apply to the new hospitals that are coming down the pipeline in the next 5-10 years, that we don't have to rely on these contracts, that we don't have to rely on the pain share, gain share mechanism to drive the bus. We don't have to rely on energy. Well, we do have to rely on energy target to sort of set that stage, but that's not the mechanism we have to rely on. If an hospital from day one is built in a way that it's performing to that standard of high performance, we wouldn't have this conversation to start with. Like, what is stopping us? Maybe I'll start with Miles. So what are some of the things, Miles, you think we could do and leverage from one of your facilities as an example, that whether that's a process, whether that's the right people on the team, it's probably a combination of all of those, but what do you think that we can use so that we have to use less of those levers? And I'm going to come back to those levers and how successful they have been in other projects, but what we can do to improve a process of an existing hospital or a new hospital that's getting built so that we get a high performer for day one.
Well, I think it goes back to some of what has been said. I think you need to have and make it very clear what your energy objectives are, what your sustainability objectives are, and that has to be aligned with the team over and over again. So I think, and I would say all facilities, we talked earlier about data being so important, and this benchmarking that you've seen, this chart is so important. I think when you're setting those goals, you need to take a look and provide the feedback loop right away. You can take this data to the design team on day one and say, this is how facilities have been performing. we can do better than this. This one has to perform better than the previous ones, or we're not doing our job. And then you kind of have to reinforce. I love that comment earlier from George about aligning and realigning, and keep doing that. Keep going back to those things. I don't think it always has to be so complicated either. I think if you have a basic monitoring system, which every hospital has because you're being billed, and you have a building automation system, you've got some pretty good tools that you can use to see what's going on. And now you have to get the team looking at that. And how can you do that? And I think that's where you have to get these meetings together and get them focused on areas that are important. This list that you've produced is a great way. Are you doing air handling scheduling? And quite often that's not being done. Now, do you have all the tools to do that? Most places, I think the new facilities today do. If they're meeting the basic code, they have what they need to hit a certain baseline performance.
Amir, go ahead. Yeah.
If I may add to that, so yes, I agree, but I think we also need to have that focus of our energy efficient, a team that's looking at the energy efficiency embedded in the team, whether it's on the hospital side or it's on the Project Co side. I'd say it needs to be on the Project Co side, not on the hospital side, because, that's what the model is all about. But there needs to be a embedded energy efficiency, somebody embedded into the project, whether it's a team or a person, looking at improving energy efficiency on an ongoing basis. And that is missing, especially from our project. And that's not just true for new hospitals. I believe if that was the case for existing hospitals as well, we'd go leaps and bounds and perhaps come to a better place.
We have a question. Sarvan, go ahead. It's off.
It's good. I'm on.
Yeah.
Technology problem. Just one of the point I wanted to make as an owner and ex-FM service provider, the conversation is not just about energy. The FM service provider, you can have them dialogue and converse with you about some of those recommissioning measures that are really to their benefits, not on the energy guarantee only, but you would reduce the wear and tear on the handling unit, the pump, the fan. There are entities to obviously reduce their life cycle costs because it's already planned at bid. And therefore, anything that they don't expense, it's money coming back. So it's a big loop that the conversation is not just about energy. Educating the FM service provider and the energy manager on those opportunities is a good way. You can, as we did at CAMH, we invited Mandy Penny's team. They educated the service provider's energy manager, and we have achieved some of those measures, and we'll see benefits in future years at no additional cost. Again, it's a conversation, it's an education, it's information, and you need to challenge them and challenge their ego as well.
Thanks for
Gain share doesn't cut it in a P4 environment, especially when you have a 5-year baseline reset, no matter what the model is all about.
Yeah, I think we got to have a sort of an open-minded conversation on these levers, which includes pain share, gain share mechanism. Is it actually working, and do we need it? If we don't need it, how do we ensure that the performance of a hospital is what it's supposed to be, it's coming out? I'm just going to go back and sort of ask, we talked about sort of some of the levers where energy targets is one of the levers, pain share, gain share is another lever. Glenn, from your experience, let's talk about from FM side, on site, how much of those have helped you or sort of forced you, in other words, to do performance or operational changes? I'll just do a hypothetical question. Like, if the targets were met from day one, would you have done this, what you have done now?
I certainly like to think so. Yes. It's turned into I won't call it a hobby project. It's been a focus for us. And we're lucky enough that we have a full-time building automation tech on site who's here actually. And he's made a focus out of improving efficiency that, you know, we do see the benefit of in terms of gain share, but we also see the benefit in terms of being toward the top of the chart on these sort of things. And hopefully, you know, getting JCI's reputation out there as an efficient service provider.
Yeah, I think that's it's a leadership-driven focus. Is who doesn't want to see their facilities at the top, or whether you're an FM provider or an owner, to the top of the benchmarking chart. Sure, sir.
Hello? Yeah. Just a comment. Thank you so much, Amandeep. Really appreciate all the hard work, and to the panel. Just to have a comment on setting the thresholds for the energy target. I understand the situation in South Catherine is a little bit different. That was an older contract where previously, like we take like several years and take the weighted average of those, and then you weather normalize them and set the target. This is obviously not working because it can be driven in a certain direction by not performing well in the beginning, and then whatever you do, you'll be lower than the target. But later on, when we went into the process of having energy modeling tools, the mathematical modeling tools, like starting from eQuest and all the way to Energy Plus, we know now that the targets currently, and I say specifically since South Niagara, which is one of Amir's familiar with very well, from South Niagara onward, all the thresholds for the target are actually based on the list that is the best, like the best performing hospital. We can see like no target being set from South Niagara onward was actually look at the list and say, oh, that would have fallen on layer 12 or 13 of the list. No, it's really, really the best possible. As we all know, the energy schedule is a living document. We always try to improve it from lesson learned, from previous experience, from meetings like this one, from individual chats with service providers, with the owners, and with the builders, with our partners at PCL, Ellis Doan. So it's good, it's living, it's progressing, and the targets we're seeing them getting more and more into the top tier of the list. Thank you.
Thanks. Sorry, if you missed it, it's Mohammed from Infrastructure Ontario. So if you have any questions about targets, go to him. Just joking.
And just let me add to that what's happening in Ontario is still world class.
Yes.
Like we shouldn't dump on ourselves here. We look all over the world. The top performers here are doing well, and the issues that we're encountering here are being experienced everywhere. None of this is easy.
Ian. I want to sort of also open it up. If anybody has any questions, please jump in, because this is a conversation. We want to make sure we address any of your questions with our panelists. So
I do have a question, so I'll interrupt you. Yeah. My question builds on what Mohammed just said as well. And I think it's what you said, Amir, that why I was shaking my head or earlier, is I feel like we did try and do that for South Niagara, and I'm curious about why you feel that wasn't maintained. And I know that maybe Cliff will touch on that about in the process, but from your perspective as the person who's seeing the operations, can you touch on where the failings were from setting the target basically equal to Humber, and then how that eroded after?
Yeah. So, I think I'm more so from facilities in operations side. I'm not part of the project team, so I don't know the exact details of how we didn't, but really the feeling that we had was we need to beat Humber. And at the end, it was more of a competition thing for us. And I don't think that we have with the intensity. So that was the letdown, so as to say, for me, that I refer to. Now, it may actually be pretty close and, the energy intensity and whatever. And at the end, when, we do go into performance, because you guys did a great job working on that project, really respect all the work that was done. And we may be among the top performers, but if we don't beat Humber, then we've lost. Sorry, that's what it is, right? Because that was from 10 years ago. How come we can't beat 10 years later with better technology and everything and having a template still lose?
Well, the team doing the project is in the room. They now know what they can do is you.
Well, I'm competitive, right? So,
So I just want to use this opportunity to, I think, address one of the other issues that we currently facing in the industry is the talent. Through the specifications, we are seeing the fundamentals are getting more and more clear as we talked about. The elements of a high performance hospital is out there. Like we don't have to second guess ourselves whether it needs a heater cover chiller, whether it needs a condensing boilers, where the loop needs to be tied in. Those elements are there. Once you get a facility which has those elements, how do you operate it? I want to hear, starting from Glenn, from you, and then sort of Miles, is what are some of the talent that so these plans are getting complicated. We have heater cover chiller tied to a boilers plant, to a chiller plant. We have enthalpy wheels in all these. We have ventilation scheduling done at a room level, at a system level. What sort of expertise are you thinking that's currently needed to operate these facilities, and how do we build that talent? So it's not, we're solving one problem by sort of making or designing energy efficient hospital, then leaving it to somebody who's not capable of operating it. Like especially with the now DBF and DBFM, there's a challenge that hospitals has to take on themselves to operate these sort of integrated systems.
I think that would, to a large extent, go back to the commissioning of the facility. If you're handing over a DBF hospital to an operator who wasn't familiar with high performance central plants, I can see that being a significant challenge. We had the good fortune to get a few people from the construction side of the project to stay on in operations. So we had people coming on who already knew how the plant was supposed to work. They had the overview of the design intent, and that is a tremendous advantage. So I won't encourage anyone to poach employees, but just there's a benefit to having that experience and that continuity on the team into operations.
And Miles, like, how do we address this gap? I think you brought up in our previous discussions that you see there's a gap in finding highly skilled people who kind of understand or orchestrate this sort of complex plan. Like, how do we address that? Like, what are you guys doing for your facilities?
Well, I think we need to build the workforce around everywhere, because we need to host more events. We need to share more information. We need to document success. We need to understand failure. We need to give people the room to talk with each other, because we're all looking for the same people. I mean, we all need talented people. We need to keep them and retain them into our facilities. So, training is absolutely key. It needs to be incorporated early. And I think one of the things I heard Jason say earlier was meetings on control sequences. What a great idea. We should be having meetings on control sequences and talk through them. And how does this work actually? How should this work? What was the design intent in this? I also think that we're focusing a lot of training on the cutting edge new technologies, which is great because it's coming and it has to come. But we're also seeing people retiring, and we're losing a huge amount of knowledge in how systems work. So I think we have to pay attention to handing that knowledge down more intentionally, because we are not changing our infrastructure to the new technology as fast as we're losing the knowledge base that used to know how to operate those things. And so we have to pay some attention to that as well.
Amir, do you have any?
Amandeep, could I just pick up on that quickly? I may have misspoken right through this whole session here around we know how to do it. Like, the fact that we've done it doesn't mean we know how to do it. And I think this subject of education, Cliff, if you could think about that. I mean, with great respect to all the players involved, or all of the high performance facilities I've visited, we have the benefit of an inspired, intuitive BAS person that just gets this stuff, and they do it because it makes sense, and they don't even look at the numbers. But they're few and far between, as you say. And the flip side of that retiring workforce is sometimes building operators are resistant to change. And sometimes, God bless them, I hope they enjoy their retirement. So the new people coming in, our impression is we're seeing less courses coming out of colleges that are looking at performance and the kind of skills that we need. I say the fundamentals, not just the high-tech stuff. So this whole area of workforce development, where do you find the talent? Because generally there's again a genius in every one of these high-performing facilities, but that's happenstance, that's good fortune. It's not systemic, and we need systemic change.
And just one more thing to add to that is engaging staff, and particularly those operators of central energy plants. Sometimes they don't get the opportunity to see the effect of some of the choices that they make, whether it's turning chillers on or boilers on and things like that. How does that affect peak? That information can flow back to them. And if you engage them in the right way, oftentimes they become, how can I make this better? They almost become competitive and say, can I drive this down a little bit? Make it that way for them so that they've got those tools to use. It's not that difficult to put simple, demand profiles and things on their desk.
Yeah, and I was just gonna, while we're on labor force, I just want to say that we focus a lot more on engineers. What's the engineering solution? Everybody here is sitting in, saying, how do we drive down this consumption? And but we're in the business of healthcare. What's missing that I find, and I've said that before, as a feedback to service co's and project co's, they're going back and hiring these very smart people, engineers, to drive these buildings, but they have zero experience in working in healthcare. So there is a bit of a gap. When we try to have a conversation with the service co, we sometimes find that there's a lack of understanding from operations perspective, because the operations do have to translate into how the building is run as well. And if the understanding is on both sides, so I'm not saying, you hire somebody, a boiler engineer who's like, but, at least the leadership who's going to have that interface with the hospital, they need to have an understanding of the hospital operations, so that when that conversation happens on the OR, we need to lower the temperature by a couple of degrees. They need to also understand that, everybody is gowned up and masked and this, that, and the other, and it can get very hot for those people. So what is that, what are they asking? And then having that knowledge, they can also discuss it back, saying, hey, here's the implications, or here's something else that you can do. So it's not just that we need the smartest engineers, we also need engineers who have healthcare experience and or operating in the healthcare environment.
Yeah, I think it goes to the point in the morning around having a clinical staff buy-in, and then on the design side is as important as a regular sort of a conversation with the clinical staff and operations side as well, because usually operations team is brought into when there's an issue. They don't have those conversations around what else is happening with the clinical staff. They are only brought in, here's my issue, can you fix it? And that environment is pretty tense at that time already. The things have already been drifted downwards, and the conversations those times either are less productive than you would have in other engagements. Sorry, go ahead.
So I'll post a statement from the Vaughan experience that I described with the team. When Vaughan opened up, it opened up very efficient, but also the stability of the system and the outcome to the patient care was taken care of at the same time, to the point where, for example, I get a call from Patrick because he works very hard and does his job. And I get a call at 5 o'clock. Why is it cold in my office? Well, the system is resetting, Patrick. It's just go home. So for example, all the work that was done during that commissioning and training and setting up essentially got that outcome for the success, and the building essentially achieved not only the energy efficiency, but the patient care and the healthcare provider aspect of everybody. In your experience, Glenn, like from all the changes, did that improve the building as well, not only on the energy efficiency?
Absolutely, yeah. As things settled in and operated more smoothly, and the sequences got developed to the point that they could take up ripples like air handlers shutting down or chillers starting up or shutting down, the patient experience would have improved as well, just because they were getting a more consistent environment.
Thank you. I just have one last thing, but not the least one, and then if there's any other questions, we're towards the end of this session. Monitoring, metering, and reporting. We've seen in a lot of the healthcare facilities, I mean, there's a lot of good guidance through Schedule 36, which tells you what systems you need to monitor. How important, maybe I'll start with you, Glenn, like from your day-to-day operations, how important is that, and how do you guys make sure that the meters are working? Because that's one of the issues we notice is meter breaks, then it takes 3 months and you lose that data.
I would ask our construction partners to put the meters places that we can get to them.
Take away.
That's been one of the challenges. You do need to recommission meters fairly frequently just to make sure that they're still accurate. And I would also submit that a virtual meter where you're subtracting meter A from meter B to make meter C isn't a meter. So you basically can't have too much metering in a building if you want to improve the performance of it. Anything that you can't measure, you can't manage.
Miles, do you guys have a lot of metering in your buildings?
Well, I would agree, premised on the idea that you have the staff and people to look at the metering data. I've seen facilities that are fully metered, and they're some of the worst performing hospitals. And then I've seen ones that only have a few meters, but you have staff that are utilizing that BAS. And I think the point that was made over here earlier, it's not always about energy. If some staff are focused on, okay, what is the design intent? What are we trying to do? They're looking at balancing reports. They're understanding how much air to bring into an OR. They understand that it can be scheduled down, and they're working towards that. The energy will follow, and you'll see that in your higher level building meters. And if you have a little bit of expertise and you can get a huge amount of information from a high level meter. Mm-hmm. And I think we don't utilize that enough. I totally agree that you can get better and you can do more metering, and that's very helpful. But it's not always the highest priority. So we do have some facilities that are very highly metered, some that are, I would say the majority are basically metered.
Absolutely. I think the data is only important when you start looking at it. Otherwise, it's just the data. It's not useful to anyone. What I gathered, I just kind of summarize a couple of points, and that will sort of end the session. Energy targets are important. That set the stage for your building. It gives the guidance to project codes, to hospitals, what to look for. There's going to be talk, and I think Ian shared this morning, there's empirical sort of evidence out there that project codes and design teams can use to sort of drive their energy targets. We heard from Mohammed from IO that they're also taking that approach and sort of considering everything with energy targets as a starting point. We talked about making sure you get the right talent in the building. So once you have a building, it needs to be operated. If you don't have an operator that sort of doesn't understand the nuance of operating the building, it's going to be challenged to get that high performance through the building, even though the infrastructure exists. Having that early buy-in from clinical staff and being part of the early discussions on design teams, whether you have a representation from an hospital or you're sort of relying on Project Co, but asking those questions, how does this mean in terms of energy performance from day one, will definitely improve that process of the system. So you're not getting unexpected value injuring things that will eventually impact the performance. In certain cases, it's something what we notice is that it's something you could put it in, it's less capital intensive, but in other cases, it's so capital intensive that it doesn't make any business case after that. And whatever the levers you put in the contract, whether it's a pain share or an energy target, the business case is not there to make that change. That change would have been caught early in the design. It would have been an easy solution. Everybody would have implemented it. So these are some of the key sort of the takeaways in terms of what we're sort of coming from is on the recommissioning, commissioning, facility management, or operations side is start early, get them involved early, set a right target based on empirical data, and then have a good operations team to look after your facility. Really, thank you. This is very, very, very insightful information that's been shared. I'm going to now pass on the information or sort of session to Ian, and he will do the most important thing is the awards for today. Thank you again, panelists.
Thanks, Amity. Like, I don't know how you're feeling, but for me, great morning. These are always leaps of faith, right? You're bringing a group of people together that you know and are smart, and you hope the dynamic works and the truth bubbles up. And as always, we learn, I'm sure, more from this than anybody else does. So I say, great morning there. Before we get on to my favorite part of all of these events, which is celebrating what's working, what's going really well. Cliff, if I could, is Cliff still here? Okay, he's allowed a break. Just want to touch base with him, and I will over lunch, that he's getting what he needs, because again, keep in mind, after lunch, we're going to be talking about what have we learned, lessons learned, and I'm going to cover a lot of miles during that session with, miles walking, with my microphone, because we need your feedback there. And again, all of this, so nobody's shame, is being recorded, and all of this will get synthesized down to how are we actually going to do things better on a go-forward basis, and that's where we should be right now. But let's touch on the savings awards. So ever since 2010, we've been recognizing individual hospital sites. So this is individual facilities that have saved more than 5% of total energy. And keep in mind, we were talking about saving 55% back there, but many of you in this room who've had multiple awards know you get to 55%, typically 5% at a time. 5% in an active hospital is a good number. Like, it's very material, and it's hard to do because all the pressures are upward on energy use. Like, you never get calls from clinical staff saying, could you reduce energy, please, or change my comfort conditions, because you never get that. So the pressure is always upwards. If you can contain that pressure and fix systems and bring it downwards, 5% is a noble achievement. So we got a group of them today. Michael, are you? Is Michael in the room? There he is. You're going to come over here and find these and hand them over, or are they all in the next? You just can't get good help anywhere anymore. So no, they come, scroll on the back, and we actually did have a hospital that had to ask to move them all to a bigger wall. So that's always a good sign for us. But is anybody from Lake Ridge here? Yes, good. So Ajax Pickering. And the awards look kind of like this. So total energy savings of 12.2%. Again, that's and 18.9% reduction in greenhouse gas emissions in an old hospital. So we'll be coming back to that, but congratulations. And if you could stay here for a minute, we're going to, at lunch, we're going to go out and get pictures. They've got some beautiful backdrops here. Have you seen this? So we'll get a really nice picture that you can take back and... yeah, go sit down, then we'll get that during lunch. Okay. So I have to pick another one, all right? Oh, joy. Do we have Milton District Hospital here? I know we do. So Milton District, 14.9% thermal energy savings, 7.1 total energy savings, 8.4% reduction in emissions, going in the right. I think we got another one for you, Joanna. So if you can take that one. And again, we're going to take pictures. Oh, Oakville, Trafalgar, going in the right direction. So 11.8% emission savings, and here we are. So pictures to follow. So thanks, yeah. Congratulations. Thank you. And more good news. An old favorite. How many of these have you got now, Rob? Are you the guy with the bigger wall? Okay. Okay.
One every year.
So Ontario Shores, already the most improved hospital over the past 5 years previously, still has moved forward by another 13.1% reduction in emissions. Congratulations. I love doing this. And finally, but not least, this is a fix. This can't be true. Cortellucci Vaughan, having not only started really, really good, but got even better with 38.8% emissions reduction since they started within the program, 38.8% from the starting point.